who's on the call with respect to board members? Oscar, are you here?
Hi there. This is Oscar. I'm here.
Rosenda?
Yes, Rosenda's here.
Great. Brenda?
Yes, I'm here.
Zeke? Are we on Zeke? Kirsten?
I'm here.
Great. John?
I'm here.
Great. Fabulous. And then who do we have from OHA? I heard Jeremy.
Good morning, Dr. Banks. This is Trilby DeYoung. You've got me too. This is Colette Young.
Tom Jean.
Lillian Shirley and Kara Biddlecom will be here in a minute.
Chair Bainsburg, if you're talking, you might be on mute.
Hello? Sorry, I dropped off.
You're back.
I'm back. Yes, my mother called, and I pushed the wrong button, and I was doing roll call. So it's your mother.
Okay, we did OHA roll call, and we do have Lillian Shirley, Colette Young, Kara Biddlecom, and Tom Harrison join us shortly.
All right. Thank you, everyone. Great to be together. I'll be by phone. We want to first review the minutes from the last meeting and welcome a motion to approve the minutes.
This is Brenda, so moved.
Okay. Second?
Kirsten, I will second.
Okay. All in favor? Aye.
Aye.
Any opposed? And any abstained? Okay, great. Well, today's meeting is all about COVID. No surprise. Start the meeting with a few comments in a very important time. First and foremost, I hope you all are well and your families are well. And I am optimistic we will see a better time. But I just want to take a few comments to comment on the role of OHA and a few thoughts. And I'm sure you've all heard the clanging pots and pans to honor the healthcare workers at each night. And as a physician who trained in North Harlem in New York City, at a time I thought were challenging circumstances in the 90s, I had great appreciation then for the grit and dedication of New York City healthcare workers. But that was under normal circumstances, and I can't pretend to appreciate what our healthcare workers either in New York or in Oregon are going through now. I know that initially the demand for ventilators, hospital beds, ICU beds in Oregon exceeded, the projections for demand exceeded what we thought what the supply would be, but things look much better now. The time to the doubling time in Oregon is now 11 days compared to 3 to 4 days in New York City. And this is because Oregon acted really quickly. Our time from our first COVID death to the stay-at-home order was 9 days. This compares to a 12-day delay in China and a 23-day delay in Washington. And I think difficult decisions were made in terms of stay-at-home and school closures, and there was a lot of debate, and I think healthy debate, as to when and how severe these measures should be. But I think we're seeing the benefits of these interventions, and it's the benefit of these interventions that allowed Governor Brown to set an example by putting public health first, by investing in these interventions, and it gave Oregon the ability to set the example by donating ventilators, 140 ventilators to New York City where they're needed most. The story's not over. There's still a lot to do. There's room for cautious optimism, but just cautious optimism. We have to get through the other side. But I think that we need to take a moment to appreciate the leadership of OHA. and their good work, including Lillian Shirley, Dean Seiblinger, Carrie Biddlecom, and Pat Allen, and everyone at OHA. And my pots and pans are downstairs. I don't know where yours are. But in lieu of pots and pans, I think we should just give OHA a round of applause for putting us in this situation where we've had a robust response. We're seeing progress, and I think as Oregonians, we have a very optimistic future, especially compared to some of the states that are struggling more than us. So I had to see how the applause go on the phone. And with that said, I'll hand it over to Jeremy. I'm sure there will be plenty of robust discussion during this meeting, and I think there's much more we can learn. And, I'm sure mistakes were made and things, there's areas for improvement. But I just wanted to start off with thanking the great work of our Public Health Division, OHA. So, Jeremy, would you like to lead off?
You bet. Thank you, Dr. Binkford. Thank you, Board. Really appreciate that, and I'm glad Lillian was on the phone to hear it, because it's really been her team who has been in this for, I think, 75 or 76 days now, and we'll certainly pass on your appreciation to the team. We really appreciate it, and still have a long ways to go. I'll jump in here with a few updates. I know it's all day today is COVID-19, so it's a little hard to figure out where to start and stop, but let me give you a few comments to kind of tee things up, and then we have almost 2 hours here for conversation and discussion. First and foremost, I mean, pretty much all things are COVID-19 all the time right now. We've paused all non-critical other bodies of work, kind of starting with things that hadn't gone off the ground yet, but especially things that involve stakeholders and partners, and recognize that we really want them focused where they need to be focused, which is on COVID response. And so just want you all to be aware that things like Senate Bill 770 and Senate Bill 889 and all that work has gotten slowed down. Non-critical rulemaking, agency strategic planning, a lot of stuff has slowed down, and a lot of folks have just been redirected to COVID-19. So, myself, Dr. Arganani, a number of other folks have pretty much been working on COVID for the last 3 weeks. So, know that you all support that. That's the right direction. That's where we're going to be focused. But also want to just acknowledge and appreciate that there's a lot of other priorities and things that the board and legislators and stakeholders and others that have been working on that. Right now we just have to totally focus on COVID and pick those things back up when things slow down. I think Kara's going to give a little bit more of an update on kind of how the emergency structure looks in terms of the agency's response, and Pat previewed this a little bit last month, but let me just give you a high level. I mentioned Lillian's team has really been at this for, she probably knows the number off the top of her head. I think it's about 75 or 70 days now. This started as a public health emergency, and we've got infrastructure within public health to stand up an agency operations center that can respond to public health. But as this transitioned to a statewide emergency, we've really started to move more towards certainly public health is the lead, and this is a health emergency, and so OHA always plays a critical role. But we've really stood up the statewide emergency response infrastructure, which we stand up several times a year, usually wildfires, the ECC shooting, Malheur wildlife situation, things of that nature. I don't think we've stood it up in a response to this or to a really primary public health crisis. And so we're learning as we go, but really what we're doing is folding more of the work that's been based in Portland and connecting it into work that's in Salem. There's a statewide emergency coordination center there that has agencies from across state government pulled in. I think every major agency at this point is pulled in one way or another. I've had huge support from fire marshals and local fire and rescue to forestry, to DCBS, to DAS. And so while certainly health is kind of the lead and what this crisis is, there are elements of this that impact all of state government, that impact all sorts of other sectors. but there's a lot of other elements, and we've been really fortunate to have great partners and other agencies that are jumping in and helping wherever they can, even on issues like this that they maybe have never worked on before. We have a lot of information online, and I think Jeff's going to send some of this out to you later if he hasn't already, but we've got a great new Tableau site with daily information on updates. I think you've got an example of a daily report that goes out in your materials that give kind of some high-level daily indications of how things are going in terms of bed capacity, in terms of PPE, things of that nature. So just a huge kudos to our communications team that's been continuing to just evolve the information that's available online and get more and more up there. We have a newsletter that now gets out to 115,000 people, and so that is growing in number of subscribers, and so just have a number of different ways that we're trying to get information out there, and happy to get you connected with any of those if you're not already. Dr. Gene's going to talk a little bit more about where we're at in the modeling up, and Dr. Bangsberg, to your point, looks like we've been fortunate that we had a little bit more time than some of these other states to be able to really to prepare and get organized, and with quick action. Looks like the overall social distancing and stay-at-home measures are having an impact, but just want to emphasize that that's still 100% dependent on people continuing to do what they're doing. And so I think the challenge now is going to be not sort of letting off the gas and making sure that we we continue to monitor where we're at with the surge and peak, and not get relaxed or sort of fall on our laurels that we think we've solved it, because we still have a long ways to go. In terms of some other agency updates, I think OHA, like all other agencies and all other employees, we're adjusting to working remotely at home, and that's, I think, overall going fairly well. I think we've had technology issues here and there, but people are having to figure out how to do their work remotely. But overall, I think that's going fairly well. I think one of the limitations we've had is, at least in my division, I suspect this is true in others as well, is we were sort of in the middle of bringing staff on for really critical work, and that just becomes really difficult to do when you're trying to figure out how to do onboarding in a stay-at-home situation. So I think a lot of those hirings have ended or slowed down, and that will likely have an impact on some of that work ongoing as well. I think kind of big picture, as the economy slows down, we're sort of bracing for the impact of that like others, and it kind of remains to be seen what that looks like. The May revenue forecast, I should say May will be the next time the legislature gets the revenue forecast, and so all eyes will be on that and how that forecast shifts in the wake of the economy slowing down. OHA's budget, just to kind of, I guess, prepare you a little bit, OHA's budget is very highly dependent on the economy. As the economy slows down and unemployment goes up,
reinforce David's comments about really the terrific work that you all are doing. I want to especially focus on communication. It's one of my interests is communication and transparency, and I think the state has just done a terrific job. Work. I think that it's reassuring to providers and the public if they see that the truth is being told, whether it's bad or good. And from a transparency point of view, the degree that the details can be shared, I think are really helpful. I've been surprised how many really very sophisticated questions my family and friends are asking about models, about epidemic curves. For example, it's great. You all are now sharing the dashboard and emphasizing the epidemic curve. A week or so ago, I was feeling, share the model, explain the model that you're following, so that people can see it. I thought it was just incredible that the governor was the first to send ventilators to New York. I think to the degree possible, if we can continue being the earliest and best communicators, it will be fantastic. I would also urge. I think the folks who have been doing the webinars for providers are fantastic. And to the degree that the public can see, folks at OHA and folks in public health. I think there was a webinar more for the public on masks, and I watched that, and the folks doing that were just terrific. It's really important, I think, for them, for the public to be seeing who public health is, what kind of people these are, what kind of work they're doing, and so I think the more you can communicate to the public, it will be great. I think the Wyden Kennedy campaign is A+. I love it. It's just really terrific. So I just think we're doing such a good job because other folks aren't, and I think the public is so hungry for the truth and the truth about their situation, and that means Oregonians want to see their situation and the truth about it. And you guys have done a great job of that. The second issue I just want to raise is on the horizon. I mean, today's headlines, I think, make it clear that there's outbreaks of COVID-19 occurring in healthcare workers in Michigan. I'm pretty sure in New York. I'm pretty sure in Boston. When Toronto dealt with SARS, they had a second peak that was due to healthcare workers getting the disease and transmitting it. And again, my sense, because of the good work that's been done, is Oregon may not be having this, but we need to figure that out. And while we see some news reports here and there about healthcare workers in Oregon having the disease, I think an effort to get that organized, to be transparent about it, to look at strategies related to healthcare workers and how that can be managed, because it can be managed, is something that we should be doing. So just terrific work, you guys, terrific work.
Thank you. Thanks, John.
This is Oscar. I echo a lot of the comments that Dr. Bingsberg and Dr. Santa have expressed. And we don't have to get into this now, but this is sort of like I'll kind of put this out there for something to hopefully be addressed at some point during the presentation today or potentially as a follow-up. I know we're a ways from actually being able to return things back to the way they were before COVID-19, but it would be great to start, in terms of the communications aspect, it'd be great for OHA to start sort of kind of communicating what are some of the features that we need to start seeing in the state and to return to start even thinking about what it would look like to return to normal, because I do worry that, if folks feel like we're doing really well and there's not a peak and things are better here than in other places, that we could start kind of relaxing the social distancing, or we could start relaxing some of the restrictions that have been put into place. So I think we need to kind of think about getting ahead of that and sort of really starting putting out there, like, what are the things we need to start to see in the state to be able to even consider going back to relaxing some of these elements.
Yeah, thanks, Oscar. And I'll just say I know Karen and Dr. Jean will get to some of that in their comments as well.
I'll go to Dr.
Hi, Dean.
Okay.
Just want to say we're prepared if we go through the agenda. There's a number of people who really have thought about these things, and we're hoping we can share some of that and then have, what we don't answer of your questions or your suggestions, even the last one about what do we need to do to relax social distancing and what are some of the criteria and some of the issues around equity and inclusion. So I just want to say, in the interest of time, that we hope we have a chance to push out some information this morning and then get more of a dialogue going, hopefully. So,
all right.
Thanks.
Thanks, Lillian. Appreciate that. Okay, let's move on, and then we'll come back to questions later. Do you want to go forward?
Yeah. Thanks, Dr. Bingsberg, and thanks everybody for the kind words. Certainly appreciate that. We're working very hard here, day in, day out. So I wanted to provide an update on our numbers and talk about our current modeling projections, and I can also talk a little bit about testing if there's time. So currently, most recent report from yesterday, we don't have our current numbers today, but from yesterday we had 1,132 cases total in Oregon to date, and 29 deaths reported. We have tested now cumulatively 21,801 people, including both commercial and hospital labs as well as the state lab. So that is really a big number. Looking at our epidemiologic curve, that is the curve that everybody talks about we want to flatten. The challenges with that are, that is based on reported cases. So it's only reliable about 10 days out. So looking 10 days back, the curve is increasing, but it is not certainly not an exponential increase. And the reason that the most recent 10 days are not reliable is that illnesses during that period are not, some of them are not yet reported. So we kind of have to keep following that and looking at it, but so far it's looking okay. Other data we have that's in our daily report is the proportion of emergency department visits that are for COVID-like illness, and that has actually been decreasing for 2 weeks, which is good to see. The total number of ED visits has been decreasing for about 3 weeks, in line with social distancing, which is not unexpected in general, given that people are staying home. We also have been working hard. Dr. Dana Arganani has been working hard to increase the reliability of our data on hospital capacity. So our total beds, our ICU beds, our ventilators. Currently, we've got a good bit of capacity in all of those. Our best estimate for total hospitalized COVID-19 cases right now is 400, but I'll have to note that includes both confirmed and suspected COVID-19 patients, so some of those may not actually have it. So in terms of our modeling, we had worked with, we're continuing to partner with the Institute for Disease Modeling, which is up in Bellingham, Washington, and they are using Oregon data, including cases and hospitalizations and deaths, to model our projected cases and our projected hospital requirements. So the latest data we have, which was calibrated to data up to March 27th, suggests a slightly higher numbers of current infections in Oregon than the previous estimate, just due to an increase in the number of diagnosed cases reported at earlier time points. But it's still a really good picture. There's strong evidence that the measures we have in place, including the social distancing, are reducing transmission. The data are consistent with current transmission rates having been reduced by about 50 to 70% compared to baseline. And this is available on our website, healthoregon.org/coronavirus, and you can see the March 30th update. We also have a more recent update that should be coming soon. We're still working on the final data for that. So what this is really telling us is that if Oregonians can maintain current social distancing efforts, and these projections hold true, that we are going to be able to meet, likely be able to meet the demand for hospital beds under current strategies. And the projections for beds right now look like, with the current measures in place, we'll start to see a plateau and a decline into the next few weeks here. So we're going to keep adjusting that based on the actual numbers we're seeing. But again, I think this is just highlighting that Oregon acted early, and we're doing pretty well compared to the rest of the nation, as we've discussed. I also wanted to talk about our new data visualization. We have a couple of graphs that are on our website, and there's a blue button on that page near the top under cases or COVID-19 cases in Oregon. And that'll take you to our visualization, which shows the epi curve I talked about, and that's updated every day. And it also will show you the total number of people we've tested, including positives and negatives. So that's a helpful tool. We're also in the final draft now of a weekly report. It may come out as early as today, and that will provide a little more in-depth data to the public. That's going to have reported signs and symptoms for all the cases we've had reported to us so far. It'll have risk factors, including higher risk groups like healthcare workers and people who live in congregate settings, and it has some demographic breakdowns as well. So we hope that's going to be helpful to the public and the media and decision makers. And then I guess the next thing I would highlight is our testing. We've continued to update and refine our testing guidance for clinicians, and our state lab has done a great job of improving their capacity. They are currently focusing on the highest priority groups we have, which would be hospitalized patients with a compatible illness, and then people living in congregate care settings with symptoms. We've also expanded this to include people who are seen at tribal health centers and some of the Indian health clinics in Oregon, because those are underserved groups. For the recommendations for clinicians, we are still recommending focusing on symptomatic patients, especially people who are older than age 60, people with chronic conditions, healthcare workers, and first responders. Those are kind of our high priorities. We continue to see improving capacity for testing. Really the biggest rate-limiting factor for testing is the supply chain issues. So, reagents are in short supply around the globe, and all the companies, all the labs are struggling with that issue. So we are nonetheless testing more. We are working on getting getting some of the rapid testing out to different parts of the state, including some of the rapid PCR tests like the Cepheid and the BioFire machines and the Abbott ID Now that you may have heard about. So these will really help, but again, the main limiting factor there is going to be the actual tests and the testing supplies. So we'll stay tuned and try to do the best we can to make sure testing is happening. In terms of the question that was asked about relaxing social distancing, we've been thinking a lot about what will be our strategy to help when it does come time to relax some of those measures. And there's going to be one really big factor, and that's going to be making sure that we are on top of contact tracing for any new outbreaks that happen around the state once people are kind of starting to go back to work. So aggressively following up any reported illnesses, quarantine and isolation for those people, and hopefully very rapid testing is going to be key. There also is coming online some serology testing, which will test for antibodies. And at this point, our best evidence is that there will be some immunity from this virus, but that is not definitive at this point. So there may be a role for serology testing to see if some people may be immune, may be able to go back to higher risk settings, for example. But the details of that will have to be worked out. So I'll stop there. I hope that was a helpful overview, and happy to take any questions.
Thanks, Tom. We have about 10 minutes for questions on the agenda that we open it up. Well, we wait for other questions, which I'm sure there will be. One question I had is, New York Times this morning says that this virus seems to be hitting populations of color quite disproportionately, and that in Louisiana, 70% of deaths are among African Americans, when only 1/3 of Louisiana is African American, and the same thing is true in Wisconsin. I haven't seen race ethnicity reported on the website yet. Are you collecting that? Have you looked at that?
Yeah, that will be one of the things that is listed in our weekly report. We'll have a race distribution, race and ethnicity. The latest numbers I've seen were 2%. 2% for African American, 2.6 for Asian. So relatively low there. Although there was a large proportion in the other race group. And again, for our case reports, we just have to take the information that we get. So sometimes, it's not available. And of course, Oregon's demographics are quite different from some of those other states.
Yeah. Yes. But it seems to be. I mean, it's no surprise that vulnerable populations who are not able to isolate at home because they're going to work and delivering, making sure the food supply is running and other essential services are being hit harder. And I think it's really important for us to keep track of those disparities in real time. But I'm glad you're thinking along those lines. Other questions from the board? I have a few other, but I want to make sure that everyone gets their questions on the table. What are your, maybe I'll wait till Kara's talk. I wanted to also talk about plans for surveillance going forward as we relax social distancing. But let me just emphasize one point that's been made in terms of communication. I think everyone's feeling this the cost of social distancing, both economically and in many other ways, and it is working. I think you've done a good job getting material out there, but I don't know if it's going through the right channels. A number of people call me up on a regular basis, say, how come I don't hear from OHA? And I wonder, is this getting into the mainstream media in the way it should? Because I think there's a real success story here and the success reinforces that the costs that we're all incurring are valuable and effective. And I think I'm worried about people getting burned out and relaxing social distancing too soon.
Well, I'll jump in. I think that's very much on our minds as well. And as I mentioned earlier, trying to really prepare for the third round of stuff is going to be shifting to trying to be able to explain to folks why we need to keep this up. So it's definitely on our minds, and I appreciate the comment. We'll be sort of transitioning to more focus, I think, on that as our communication strategy as a whole.
Yeah. People are asking for Andrew Cuomo. Someone in the media giving a daily update. There's a lot out there, but would think strategically about how to connect it with in mainstream media.
Yeah, I was
Any other questions?
Sorry, Dr. Bangsberg, this is Kara from OHA. I just wanted to respond a little bit to your question and comment around communications. It's really helpful to know what you all are hearing the needs are in terms of communications. I also wanted to share a little bit about the work that has been done to date. So in the just a kind of a quick overview of what OHA has done around communication. So in the last month or thereabouts, there were 1,300 documents that had been created, and many of those were translated into 12 languages. That includes the website and the governor's Stay Home, Save Lives campaign. And some of the work that is coming forward are we are working. I think others mentioned earlier to increase the number of videos. We have some videos in Mom with Spanish subtitles on our website that we've done, and we'll be working with another communications contractor on communication outreach through social media and other pathways to reach underserved communities. So certainly, as all of you move forward, if there are other ways that you're hearing community members want to get information and be reached out to, please feed that back, and we'll put it into our culturally specific communications planning.
Thank you, Kara.
Hey, this is John. I do think it would be great to consider a daily communication of some sort, like New York has done. I mean, they're in far different circumstances than we are, but I think that helps the public or a subset. I know that it's a very complex communication world. I know from some work I did that was key in Toronto. The city would listen in, and I think my guess is a lot of people in New York are listening in every day to the governor. I don't think it needs to be the governor. I think it could be a variety of folks, but something daily that is designed to tell the public what's going on and just give them a sense of how things are going might be worth doing.
To reinforce the good work and the measures you're taking and the way everybody is contributing throughout.
You bet.
Let's move on to public health emergency management. I think it will be led by Kara Middlecom and Colette Young.
Yes. Good morning. This is Colette Young. I thought I would just take a minute to kind of help us all understand the scope of the work and the responsibilities that OHA has in the context of emergency management. So in Oregon Emergency Management, our hub is Oregon Emergency Management down in Salem, and there are a number of emergency support functions that the different agencies across the state are responsible for. And you have a detailed handout on that if you're interested. We are ESF8. That's public health and health systems work. And the way that we think about the work that we do and structure our incidents is really to think about three different buckets of work. The first one is containing and mitigating spread, communicating risk with partners, and then moving resources. And so I'm going to just dive briefly into each of those. Containing and mitigating spread, the work that we are doing and continue to do with partners is first building the surveillance system to understand the scope and spread and then forecast what's to come. Investigating contacts of cases to limit spread when possible in hotspots. Work on non-pharmaceutical interventions, and that is anything from the Stay Home, Save Lives messaging to infection control assessments in congregate care settings, thinking about PPE, staffing, testing, and there's a whole information system structure behind that. And then coordinating surge across the continuum of healthcare. That is a few words for a lot of work, but just to give you an overview, I'm going to keep going on to the next bucket of work that we do. And we've been talking about that. That's communicating risk with partners. We have a liaison branch that's engaging partners and those who are most vulnerable, and I think Kara talked about that a bit. We have a health information team that does epidemiology, modeling, and provides clinical expertise. And then we have public information officers and those who are working with the media. But I wanted to take a minute here because, Kara, I didn't know if you wanted to highlight what the liaison branch is doing.
Oh, sure. Thanks, Colette. So, again, this is Kara, and in your meeting materials was a sample org chart from our liaison branch that's supporting this work. One thing that I can say is, we really tried to mobilize early on and tap all of OHA's resources across the agency to make sure that we were plugging into vulnerable groups, communities of color, specific populations at high risk of COVID-19 disease, and make sure that we were both being a direct bridge into what the community needs are and being able to respond to those and have, in some instances, some direct points of contact so that as there are issues or guidance needed, et cetera, we have someone who can help flag that and be the gateway into our incident management team. So, this liaison group continues to grow and expand based on where we have needs, but you'll see a big portion of our work is around supporting local and tribal public health authorities as they carry out their functions at the local level, so answering questions, making sure that they have information and resources to do their jobs. We worked very early on with the Oregon Department of Education and the Early Learning Division, particularly once the school closures were occurring, to provide additional guidance, continue to provide information and guidance around child care, especially around essential workers. We have a medical advisory group that have been meeting to pull together, advice and clinical guidelines in partnership with OHA. A large group that's really been focused on health equity, and again, this is where some of the communications points that I made earlier kind of dovetail in with our health information committee, but we've been fortunate to be able to rely on the Office of Equity and Inclusion and the Community Partner Outreach Program in the Health Systems Division to help us have direct lines in. We started early on in the liaison branch with weekly community calls, and we have we actually offer those weekly in English and in Spanish. Weekly, the invites go out to 650 partners. About 500 participate on the English language calls and about 50 on the Spanish language calls. And then we've also had such a good turnout for those that we've done them regionally as well, with about 285 people per region. As you can imagine, we, as I mentioned earlier, we really want to focus on populations at highest risk. So doing work with justice settings, the Department of Corrections, Oregon Youth Authority, county jails, for example, working with DHS on people with disabilities and older adults in long-term care facilities and so forth. And then lots of work with behavioral health as well. And finally, the kind of restaurants and businesses, we've been working with the Office of Emergency Management to make sure that we're communicating with the business sector and hearing about those needs and being able to meet those. So that's just kind of an overview. Lots and lots of calls happening every week with lots and lots of stakeholders, and we continue to build this out as we identify those needs.
Thank you. Thank you. I just want to go on to the third bucket, which is moving resources. Because this has moved from a public health emergency to a statewide emergency, under the governor's direction, we now are moving resources and allocating scarce resources through ESF 7, which is the Department of Administrative Services. So they are taking over the allocation of resources so that we can focus on the work that we just described, the containing and mitigating. If you think about the course of our response, we've been at this for 2.5 months. The first month or so was really a focus on building the surveillance system to ready for testing, to actually identify cases and to do interviews and work around those cases to make sure we didn't have hot spots. Then the second month has really been, March has been completely about prepping for surge. I think the question we ask ourselves every day is, are we ready for surge? What do we need to do to be ready for surge? And now we are crossing our fingers and hoping the modeling is correct. And what we're thinking of to prepare for in the upcoming months is really how do we build a system of case and control investigation that's going to allow us to identify hotspots quickly and wrap care around those hotspots so that we don't have clusters or outbreaks once we get past the peak, which Tom is telling us, is in the near future, possibly. So that's really OHA's role in this, and I can tell you, having now been several weeks into this effort, I'm grateful to have the other ESFs partnering with us and coordinating to take on tasks. That is really the overview, and if you have any questions, I'm happy to respond.
Colette, this is David. Could you go a bit more granular in terms of how you plan to identify those hotspots? And when you identify them, your capacity for contact tracing?
Hi, David. I'm going to jump in a little bit because I think you've identified where we need to go. Up to this point, I think both here in Oregon as well as nationally, most of the responses to this outbreak have focused on caring for people who are ill, identifying who's ill, caring for them, and protecting healthcare workers to make sure that they don't get sick or carry through the community. I think where we are now is preparing for that second impact where really it is the prevention that we're trying to do. Now that we know, we seem to have put into policies and mitigation efforts that is, to the best that we can guess. I mean, everything could change in a day or two, but to the best that we can guess is actually helping to slow the spread in our community. So the next stage will be how we can come together in a resource-confined environment and who we can identify as partners to really help us to do that identification of not just testing, but then once we know who people have been in contact with and have a statewide network to do that contact tracing and testing. So that's kind of, we're in the planning phases for that. But you're definitely correct. That is what we need to do to get to that next stage of mitigating and stopping the spread of the disease throughout Oregon.
Lily, what are your thoughts in terms of passive surveillance, in terms of testing people who get ill versus active surveillance and going out and finding
that's a resource issue. I mean, we know that this is a tried and true way for us to do our public health work, and right now we don't have the resources to be able to do that. But we're preparing to be able to do that. Let's put it that way. We're ordering from anybody who will give us any of the materials that we need to be able to move ahead on that once we get an infrastructure in place to be able to do that. Right now, we can start with the positives that we do have and open that circle, kind of in concentric circles around them.
Mm-hmm. And is the resource constraint people, money, or test kits, or all the above?
This is Tom. The resource constraint is really, as I mentioned, it's really the supplies and the supply chain. We're not having significant concerns about lab staffing or lab capacity. We have lots of labs around the state that could be doing this testing right now. They have the machines. They just don't have the COVID-19 tests. So that is the main issue.
And this is Colette. I just wanted to add, yes, and one of the key points is that we don't have a successful treatment or vaccine yet. And that changes everything in terms of handling clusters and investigating hotspots.
So we can,
but we're moving that way.
Yeah, and we can have them isolate. You know, if I live in a family and I've had contact with someone, and my grandmother or my mother lives with me, I mean, it would be good for them to know that I've had contact, and then, to build out on that with our mitigation strategies until we get to that widespread ability to know.
One of the interesting and I think important things that we're doing right now is offering virtual assessments of infection control in congregate care settings. So that we're not exposing staff or using up PPE, but we are using the national guidelines and criteria and walking through with administrative staff through their facilities to talk about where the opportunities are for them to better cohort or protect their processes, protect their residents, and it's an effective way to communicate. And infection control, non-pharmaceutical interventions are really where it's at right now.
This is John. Could I ask a question?
Go ahead, John.
Yeah, could you just clarify? I mean, I look daily at the status report, and you all have a table in there, and it has a red, green, yellow indicator about, which areas are adequately resourced, which aren't. And my sense has been one area that's consistently red is public health, and I had taken that to mean that there wasn't enough staff to do the sorts of things that you're talking about now, to really get out there and figure out, do all the contact tracing and things of that sort. I mean, I live in Washington County, and it's been really interesting to watch Washington County emerge as a hot spot. And from what I can tell, when Washington County communicates, they're not sure, why that's happened. And so I'm asking, so it's not people. You have enough people to do all the contact tracing and stuff if and when, there's testing, there's other sorts of stuff like that. You have enough people to do that. Is that correct?
So, John, I think the system as it currently is, of course, has been unfunded for, eons, as we all know here in the public health world. And no, we don't have enough people, and we don't have enough resources as the system exists. So the reason that this is an opportunity for us, particularly looking at all the foundational work we've done around public health modernization and how do we do our work differently and how do we think of our partners differently rather than just governmental public health. So that's a big part of how we need to move forward with planning to move to the second stage of surveillance and mitigation. You're right, that isn't there now, but we have to be creative and also, rather than creative, because usually when you say creative, you think, oh, those people, they're making things up. I would say be innovative with understanding the resources that we have and how we are deploying them in a way that might be unconventional and might be different partners in a way that meets the need of the pandemic as it is now, and learn from that, not just redoing all the things that we did the way we did them before. I think the example that Colette gave you, how can we conserve PPE? How can we protect the workforce? And how can we get, more people to have the benefit of those our health-acquired infection staff's knowledge through thinking about how we can do this in a different way. I mean, I think that's where we are now in terms of the whole public health system.
Lillian, just as Kara is in contact with our school public health and several of our students who have offered to help with contact tracing. So as you need more people, we have a pool of well-trained and motivated people to help.
Exactly. Thank you for that. And I think that there's other areas in the not-for-profit sector, as well as a lot of our EMTs are currently available, if you will, because they're not doing normal transport from, say, nursing homes to regular appointments. So we're really looking to think very innovatively about how we can do this.
Let me open up to the rest of the board for questions.
This is Brenda. Lillian, I really appreciate that last comment around creative partnerships, and certainly I know you're looking at the primary care sector and the FQHCs in particular to support that work. I think it's really critical what you're doing.
Hi, this is Kirsten. I just want to echo that. From the perspective, we're working with our members on our healthcare members, those working in clinics. Some of them have been redeployed to help in other settings, and I just think this creativity is so beneficial and appreciate the effort going into it.
Thank you both. Other comments from the board? Questions?
Yep, this is John. I just think the public would be mildly reassured as this evolves if when we begin to go back, if they were certain that there was the capacity, if, a hotspot showed up, that there was a group of people who could get there, had the resources, to put that little fire out. That would be really reassuring, and I think whatever we need to do to get that capacity up and ready should be a high priority.
Thank you. We thank you for the support. We agree. It won't be. It'll be a heavy lift, but we're committed to figuring it out.
Let me ask a couple questions on some special populations. In the rest of the country, we're finding that jails, prisons, and long-term care facilities are especially at risk. And Kara mentioned those, but I just wanted to hear about strategies to both monitor for infections and respond to transmissions in those settings.
Sure, David, this is Kara, and really our approach in working with these settings is early on when we reached out to our partners across these sectors to make sure that we could, number one, get together and develop guidance based on best public health practice and science for each of these settings to practice infection control, be able to mitigate the spread of disease. And so, for example, we have, and then we continue to update them. So long-term care guidance, working with the Department of Corrections for guidance in their correctional facilities, the Oregon Youth Authority's various facility types that they have, jails. And so we bring in our content experts to help inform that. We're also able to help support a limited amount of testing in each of those facilities through our state public health lab, essentially to help identify where there is an outbreak within the facility so that we can, again, help support the immediate deployment of infection control procedures, cohorting, isolation, that type of thing, making sure that staff are routinely checking their health, make sure that there's no staff spread of illness within a facility. And so that's really our role, is to provide the public health science connection to the State Public Health Laboratory for the identification of outbreaks, and we continue to do that. We're very concerned about the health of vulnerable populations, and so having staff directly working together with our partners has been critical.
And you mentioned, I mean, in our conversation we talked about sort of limitations of the supply chain of test kits, and is that a limiting factor in terms of doing an outbreak investigation in a jail or long-term care facility?
It is not at this time. Science tells us that we need to test roughly 5 persons to identify whether or not we have a cluster of significance and implement infection control and non-pharmaceutical interventions at this point. And so we are moving forward with that guidance successfully.
Okay, thank
you. And just to echo, this is Kara, one of the challenges about this is you could test negative today and then have an exposure elsewhere and then test positive in, a couple of days. And so trying to make sure that we are first and foremost practicing appropriate infection control procedures when we have identified that there is illness within a facility is the first step of protection, alongside some of the other pieces that are necessary for monitoring disease. And so that's where, making sure that we have a regular pulse on what is happening is important.
Thanks, Karen. And then just to add to that, in congregate settings, we consider a cluster 1 case at this point. We're assuming there's community spread, and once you have a congregate enclosed setting and you have 1 case, you're likely to have others. And so implementing all the controls that we need to, every tool we have to reduce spread is what happens at that point.
Can we talk a little bit about how we're thinking about that in non-congregate settings for the homeless population in particular?
Thank you, Brenda.
I actually can't speak to that, but I can get information for you. Thanks.
This is Oscar. I have a question about the CARES Act. I believe that there was some funding that was connected to public health, and I was just kind of curious about Oregon's efforts to try to be able to secure some of that funding and potentially utilizing it for some of the capacity constraints that we currently have.
Yeah. Hi, Oscar. This is Kara. The Oregon Health Authority has received $7.8 million total from the CDC to help support the ongoing costs associated with this response. And so we're in the process now of getting those dollars out to local and tribal public health authorities to support their work at the local level. This is in addition to the $5 million that we received in state general funds that have already gone out to local public health authorities and tribes. I would also add that we have received some additional flexibility from our federal partners to the extent that they have granted that in terms of, for example, utilizing staff who may be paid by a different funding source other than communicable disease, being able to use them in incident management at the local level. So we have and will continue to get those dollars out to help pay for staff at the local level that are involved in the response and potentially bring on more staff to support them as well.
Other questions from the board? I have a question for Tom. You mentioned the Bellevue model, and what what is the difference between the Bellevue model and the Institute for Health Metrics and Evaluation model? And I've also seen some of Peter Graven's models. And are they saying the same thing, or are they saying different things?
Hi, John. This is Lillian. Actually, Tom has left, and he and Dean have been dealing with that. I think yesterday, we had some work done and released, I guess, through the governor's office. I can have Dean or Tom get back to you on that specific information about which model and what the methodology is, if that's okay.
Okay. All right. Thanks, Lillian. Okay. Let's move on to COVID-19 health systems response, which will be led by Trilby DeJong and Jeremy Van de Heij.
Thanks. So I'll jump in here, and Trilby, feel free to add any color commentary as I go through this. A couple weeks ago, the governor convened a task force with several subgroups to it to really recognize that we saw this surge coming, but we're fortunate that we are in a spot where we probably had a couple weeks head start compared to some of states like Washington, and so really wanted to quickly convene folks and figure out what we could do to best help them prepare, or how the state could best support health systems preparing for this surge. Really, I mean, this is in the wake of recognizing that all the models, without intervention like social distancing, were going to show that healthcare systems resources were going to be really quickly overwhelmed. And we convened groups in three large categories: emergency medical services, hospitals, and long-term care. So kind of thinking about, for lack of a better way to explain it, sort of the flow of patients in and out of the system, from first responders and the EMS system to hospitals to long-term care when patients are discharged and still needing long-term care services. Had probably roughly 100 folks that met very quickly over just a couple of day period. And what we really learned was that there was sort of a few common needs or objectives that folks saw that really ran across those. And so while we started the conversation with a EMS conversation and a hospital conversation and a long-term care conversation, what we heard from folks was really that there were some common objectives and strategies that would be most helpful that really ran through all three of those. So let me just run through. I'm kind of on slide 5 if you're trying to track on the slide deck. But let me run through the four main objectives from what we heard from folks. The first and foremost was really around the state could play a role in terms of supply chain management. The issue that's first and foremost in front of everybody's mind is personal protective equipment, but there's other issues such as ventilators, as other supplies or equipment are needed. The state could really play a role in terms of trying to help procure or obtain equipment and help distribute that. The second was, actually I'm going to jump to objective 3 because I think these kind of go in a different order. So first was PPE, second was workforce, and how do we really make sure we've got the necessary workforce. What we really heard from folks is you're not going to be able to get folks to show up to work if you don't have PPE, but you really can't manage hospital capacity if you don't have adequate workforce either. So first and foremost, kind of addressing those supply chain issues. Second, workforce, and then third was really optimizing the hospital capacity that we have in the state. You've seen from the daily report that's in your packet that we have about 6,500 hospital beds in the state right now. They're about 40% of them are vacant. What folks really landed on was not necessarily building out additional hospital bed capacity, but really thinking about if those beds start to fill up and we start to reach capacity, what are the things that we can do to really decompress that and move folks that have a lower acuity level to a lower level acuity site and maximize the hospital beds for higher acuity patients. So that was sort of the third bucket. maintaining transparency and coordination, and that the state can play a unique role of really helping coordinate the emergency response on the ground, recognizing that it's the health systems that are on the and EMS and others that are on the front lines, and the state's really playing a supportive and coordination role in helping get resources to the right places. So let me run through just at a high level some of the examples of strategies that came out from these objectives. In terms of procuring and distributing critical, and I should say where this ultimately went was a report summarizing folks' input, and then that has all fed into our emergency management system. And so these are all at various states of implementation across the statewide emergency response system. So the first one around procuring, distributing medical supplies, optimizing the use of existing supply of PPE, procuring new sources of PPE, and really aligning the management and distribution. And this work is well underway. And I should say, while we were even convening this task force, a lot of this work was sort of already underway. And so a lot of it actually confirms things that we had in motion already, which was good. So we've now centralized PPE procurement and collection and distribution out of a warehouse in Wilsonville that's being run through the Department of Administrative Services and the National Guard. And as of late on Friday, the National Guard actually took over at least parts of distributing that PPE out to communities. So as we're getting PPE in from the federal government, as we're getting it from sources that we're procuring, we've got a sort of centralized hub where we can collect that and distribute it out based off of what counties are reporting is through their emergency management system is needed. That's not to say it's not to say we always have enough PPE to get everybody exactly what they wanted, but we have a process now where we're collecting as much as we can and we're distributing it out to counties. Other examples of this was the distribution of ventilators. So as folks know, we've had a number of ventilators that we were able to obtain from the federal government. We've now donated those back for New York because there's more of a need there than here right now. But this is just another example of where the state can play a role in terms of trying to procure supplies and get those out to communities. So on the second one around optimizing, and I realize I'm kind of going back out of order, but optimizing hospital capacity, there are a number of things that came up out of that. Really leveraging EMS providers in a better way and trying to divert patients from being in the hospital in the first place. So we identified things like opportunities for paramedicine, opportunities for EMS providers to be able to treat patients at home or be able to be for diverting them to lower levels of care. Traditionally, you can only be reimbursed if you take somebody to the emergency room, which is sort of a crazier rule in the first place. This is sort of an example of, I think an area where we've been trying to make some policy progress over the years, and this actually just kind of moves that forward and really helps utilize those providers for more than just being able to take people to the emergency room. Trying to get folks in and out of the hospital into long-term care as much as possible, and so we've been putting out guidance around appropriateness of when it's appropriate when somebody's in the hospital to be able to be moved to long-term care, and are working with long-term care facilities and DHS on various guidance in that area. On to slide 9 now. So optimizing hospital capacity. Spend a lot of time talking about establishing some type of step-down site or an ability to do some statewide monitoring of hospital bed status. So a couple things that we've made progress on this front. So on the hospital bed status, we've had a tool called HOSCAP, which stands for Hospital Capacity, where we monitor open hospital beds in the state. It's largely been something the state has provided as a tool started with we really identified an area of these kind of step-down facilities. Again, we're not at that spot right now. We've got over 2,000 open hospital beds, but this concept of they're facilities you can stand up to take patients out of a hospital if those hospital beds start to fill up. So we received a waiver from the federal government to be able to use ambulatory surgery centers in a way that they can't traditionally be used. So we put out guidance to try to connect ASCs that are now empty because we're not doing elective surgeries with hospitals, so that can provide some potential decompression if needed. I'll come back to this in a second, but what we've actually found is that there's a lot of these conversations happening around the community, and so we're really actually starting to transition to how do we track where folks are at in terms of building this kind of intermediary capacity, and then how do we best support them. So I'll come back to that in a second. Objective 3 around mobilizing the necessary healthcare workforce. This is a big area that folks had a lot of attention around. It's not just healthcare workforce; it's also administrative workforce. A lot of folks are becoming unemployed at the same time that we could have shifts of needing more healthcare workers in certain parts of the system as surge happens. And so we've stood up a internal group that's really doing a whole number of things around workforce, from scope of practice changes to be able to bring in providers that aren't currently licensed who maybe retired recently or reinstated licenses quickly. So there's a whole area of work that we're looking at in terms of how do we make sure we get workforce to the parts of the system that need it in a surge situation. And then finally, maintain transparency and coordination around the emergency response. So this kind of comes back to the intermediary kind of facility piece. So what the task force recommended was that we really build off of regional healthcare coalitions that had been launched over the years to really do hospital emergency preparedness, and that we leverage those regions. Basically, there's liaisons out in various regions around the state who have been working with emergency managers in hospitals and counties and tribes and others, various partners, for issues like responding to a situation where you have a mass casualty or you've got surge issues. And so the group landed at we should really sort of beef that up and utilize those regions. So where we've actually, since this report first came out, where we've really leaned in on is actually this really beefing up this regional approach. So we started to think about how do we actually go out and build, or do we need to go out and build these intermediary care facilities? And what we quickly realized is that a lot of these conversations are already off the ground around the state. Various hospitals have started to implement surge plans. Folks are out looking at various facilities where they can do that decompression themselves. So we switched gears a bit here and have really, over the last week, just really doubled down on this regional approach. And so we just currently have only had a few liaisons, and we're actually building out teams for each of these regions. And the idea is that these teams are having daily conversations with all of those healthcare partners in each community around what do they need in terms of surge capacity. And we're adding a lot more capacity internally to really help organize ourselves around those regions. And so the idea is that as we're learning what communities need to respond to surge, we're actually putting folks in Salem who will be sort of the troubleshooters to help navigate the state and federal resources to be able to help quickly deploy whatever's needed. So folks are saying, we're looking for building a facility or adding beds in a particular type of facility, and we run into a regulatory barrier, that these liaisons and their counterparts in Salem can quickly find the right folks internally who can go break down that barrier. The issue is we really need we've got a facility and we've got beds and we've got staff, but we need funding, that we can then internally organize around what FEMA can bring or what the state can bring. So we recognize that as, one, we've gotten the surge has not come as we anticipated, and so that's been helpful to actually allow us to build some of this regional infrastructure out, but recognizing it still could come, but it's going to be really community by community specific, and that our role in the state really needs to be supporting those health systems and folks that are on the front lines, and that what they need varies from community to community. process of getting these regions off the ground. We're working on each region having a point hospital that is kind of the main organizer of tracking beds and facilities and can help bring other health systems together to help solve any surge issues in partnership with us. And over the next week, we'll be really ramping this up and really using it as a tool to be able to support communities on whatever resources they need to bring. So that's our overall update on what came out of this task force. Happy to answer any questions.
Thanks, Jeremy. Open it up to the board for questions or comments.
Dr. Banksburg, this is Trilby, and I just want to add one thing to the information Jeremy's provided, and that is just to let board members know how wonderful it was to see the response from our stakeholder partners for this task force. And we did stand it up very quickly at the governor's response, and we just had tremendous participation. And I think it served a very valuable function, not just in communication between the state and these stakeholder leaders, but also across, hospitals, long-term care, EMS, and hospitals. And it was really very impressive, the willingness to collaborate around these really important data collection initiatives, the PPE, validating that, the different types of information we were receiving on that, and working on this bed capacity tool. So it was really very gratifying, and just a shout out to the leaders in the community for coming together so quickly and so collaboratively.
Thank you, Trilby. Comments or questions from the board?
Yes, David, this is John.
Yes, go ahead.
Yeah, Jeremy, Trilby, again, really great stuff. So as I listen, so would it be possible for a region, for example, let's take Southern Oregon, where there's some COVID activity going on, but not to the degree there is in the metropolitan area, where their options might be to focus more of the COVID activity in a limited set of places, and allowing other folks to come back up in terms of the traditional health services that they're providing. Because, one thing I've been impressed with is how striking the reduction is in traditional health services, whether it's in the emergency room or obviously elective surgery. And while I think that's terrific, I know there's some communities where that's going to be a challenge to some of the healthcare organizations, whether they're small physician practices, small hospitals, et cetera. And, in some respects, Oregon may have the good fortune of having some regions that can do that, while other regions need to, be more prepared for all hands on deck everywhere. Is that discussion going on?
So I think there aren't any plans underway right now that I'm aware of to lift the governor's orders around elective surgeries. Certainly there has been a decrease in a lot of healthcare services, and we've certainly heard from parts of the state where folks are struggling, rural hospitals and some others, and we're trying to address those issues as they come up. I think if what you're asking is, can we start sort of loosening restrictions on elective surgeries or whatever in parts of the state? I think that's a longer term conversation that we really need to see how things play out with social distancing as we need to get through the next couple of weeks, and don't, I think, want to let off the gas in terms of folks staying at home. I think the piece around the regional response, though, is that it does vary from community to community. I think there's some places where they might be thinking, we would want to be able to, have a COVID-19 low acuity unit in one spot, and that might not work for another community. So those are some of the variations where it's just, the healthcare system looks very, very different from one part of the state to the other. It might be very realistic to say we're going to sort of put all COVID positive in one place and COVID negative in
today. Jeremy, I was wondering, I'm wondering about, I know that the guidance for restaurants and other food serving sites goes through currently April 14th, and so I'm suspecting that the governor is going to make some new guidance around that in terms of length of time. Do you have a sense of when that may occur and what expectations, whether that'll be focused specifically on that particular guidance or whether there's kind of a broader statement coming out from the governor, from OHA, about how the public should be making sense of both the fact that we're doing really good here, but also that some continued time in sheltering in place is important.
Before April 14th, we are literally having those conversations right now. I think your point at the end is the most important one, which is we can't. It's great that Patterson will come back for great work, but we cannot let off the gas. And so that's going to be a message that's going to be really important to get out there, because if we do have a surge again, and we still run into, it's great that we've got hospital capacity now, but again, a peak could quickly overwhelm the system. So we're trying to get through the first couple of weeks of April, but we're now having those conversations and trying exactly on those lines of what comes next.
Thanks. Kirsten?
Yeah, I just had a question about PPE. Well, I guess first, thank you for all the incredible work that is being done on behalf of everybody. I had a question about PPE, just kind of wanting to match in our packets, early in the packet, in the daily updates, there's a PPE supply inventory that was shared that has pretty shocking, outstanding request numbers. And I was just wondering if you could put that into perspective. I know we don't have all that we would like, but with the kind of centralized collection and distribution system that you talked about how, I don't know, are these, can you add any perspective on these numbers and the system we have in place?
So what was the report you were looking at in terms of requests? Are you just looking at what's been in the data?
Page 6 of our packet, it's a table that has federal shipments, state procurements, and donations.
The situation report. Yeah, got it. So let me try to answer it, and I'll follow up if I get this wrong. So the requests that are on here are requests that the state has made, and are basically our point in time kind of request for what's needed. And so and then you can see obviously what's been received. We're working on trying to get better about how do we forecast this. Tracking what the healthcare system has for PPE and supply is not something the state has ever had or done before. So, our requests here are a little bit more of a art than a science of, getting requests into the federal government, and then we're getting what we're getting, and we're trying to supplement it with other procurements and other types of things. But whatever we've been getting, we've been trying to get out the door as quickly as possible out to communities. So, and communities have also been asking for, a wide variety of stuff, because again, it's not a perfect science on the ground either. And so we're working on sort of what our longer-term forecast will look like in terms of being able to actually predict what we need. But for the most part, this represents us, requesting what we think we can get from the federal government, and then as that stuff comes in, we're getting it out the door in alignment with the distribution methodology that we have with counties as quickly as possible.
Thanks.
Other questions?
Yeah, this is Tom. Can I ask a question?
Of course, yes, please.
Yeah, I don't think this is a discussion for now, but from a policy point of view, I'm very confused about the federal process for these supplies, and keep hearing other governors express concern that the current system pits them against each other to purchase these supplies that evidently the federal government actually gives these supplies to private companies who then have some influence on where it goes. So in other words, this just isn't making any sense to me from a policy point of view. And, you know, it seems if the federal government isn't able to, or comfortable coordinating this, states in some respects like Oregon and Washington and California are helping New York. States that are willing to join together and collaborate on these kinds of things should figure out a way to do that and not be vulnerable to a federal system that just seems, so ponderous and unresponsive. So it would be interesting at some point to consider a policy discussion about doing this better. Just an aside, I mean, it's also interesting Abbott has this first serology testing. Well, who's Abbott going to send this to? And there's stories about the federal government deciding where Abbott will send these to, and other stories about somebody called up the CEO of Abbott, and in the case of Detroit, fortunately, they got some of this equipment. In other words, I can't believe the public isn't unimpressed with how this has been done, and would love to see some other options considered. So maybe we should do that sometime.
Sounds good. Yeah, I'll take that more as a comment than a question. And I think we've never been in this business before of PPE, and so certainly a lot of lessons to be learned.
Yeah.
Last call for questions.
This is Brenda. I think that last comment really leads me to the question about recovery, and I know it's hard to anticipate that future state. My question is more about how you're collecting your current thinking about what new normal will look like into the future. And this isn't intended to be sort of an esoteric comment. It's actually how do we capture the learning from what we're doing today to apply it to our future? It's more along those lines.
Well, there's a couple things. As I mentioned earlier, we've never deployed the statewide emergency system to a public health situation like this, and that alone, we've done lots of tabletop exercises around Cascadia, but I think that alone, there's a lot of learning there, and like I said, we're learning to rely on and work with other state partners that traditionally you don't necessarily always think that you would, but should. And so there's a lot of learnings there that I think will be continuing to evolve and will help us better prepare for the next situation, whatever that is, that public health or otherwise. I think it's a little hard to do that, reflective immediately right now while we're in the middle of it. But there's no doubt that we're all learning a lot about that response system and how we work with other partners. And I actually think it's a lot of really good positive learning. I think we have a lot to learn from other partners, and they have a lot to learn from us around public health. It's been a little interesting in this particular situation. I was reflecting with folks from FEMA yesterday, who normally are deployed after sort of an emergency has happened, and you're kind of in the there was the earthquake, there was the tsunami, and we've
Yeah, go ahead, Zeke. Thank you, Brendan, for that question. Go ahead, Zeke.
Thanks. One, I just wanted to acknowledge also appreciation for the work that folks are doing across OHA and partner organizations, but also that, one of the things that strikes me is I keep thinking about the public health conversations we had prior to this and the public health modernization process and the identification of, just how poorly we've resourced our public health system. And, there were some additional investments made in the last couple legislative sessions, which is awesome, but still not nearly as much as what people had identified from a need perspective. And so just, there's an amount of awe I have that our system has been able to respond as well as it has, and that the people really who are responsible for it have had the success that you have, I think, in the ways that have been identified today. So truly appreciate that, and it makes me think about what it would look like if we actually had invested in our public health system in the ways that people had identified, and where we might be in that situation. To build on the conversation that other folks were just having, I wonder, as we think about, it seems to me like one of the truths in this process is that each different phase looks really different from the previous one, and that there are different things that you need to stand up in the process. I keep thinking, as I was listening to people talk about the ways in which our surveillance system, one, is clearly dependent upon the materials and resources that we have and the kinds of testing that we'll have available to us, but that also how we kind of are able to coordinate that system is going to look different than what's in place. And what I've heard is actually that OHA is really on top of that and paying attention to what that change looks like. And I just wonder, as we think about the Health Policy Board in the coming months, whether and to what degree this is a place where we can help to give a platform for how those changes and shifts occur, so that the broader public and other individuals and professionals that are working in the space can understand what that change looks like and how it requires a pivot at so many different levels in order to be able to either engage around another surge and or to begin to try to normalize coming out of this process and what moves in what ways and how we engage with the surveillance system and blah, blah, blah. But my point being that I think I just invite I'm sure that the chair and vice chair are talking with staff about what that looks like moving forward, but in as much as we can be a vehicle in that process to help shape people's understanding of what the changing environment looks like, I hope that we have an opportunity to do that. Thanks.
Very well said, Zeke. As you were reading my mind, I just wanted to say Lily and Shirley spent every penny of that $5 million for public health modernization well. We are reaping dividends from that over and over again. It was just the right thing to do at the right time.
It's a journey, folks. Stay with us.
We're here for the ride. Any other comments?
Yes, I have a comment. This is Rosenda.
Yes,
and I kind of wanted to talk a little bit about the how I see on this public health handout that Objective 4 about maintaining transparency and coordination. And then I look back at that COVID update that goes out, I guess, daily, and we have it earlier in the meeting. And I notice it has male, female, and age and all that, but it doesn't have anything about race. And I know that Oregon isn't very diverse. And is there a reason for that? And I heard someone comment earlier about certain states that had a high number of African Americans that were being diagnosed with COVID-19, and I'm just wondering, and I'm thinking about our disparities, our health disparities, and our health equity that we've been dwelling on for ever since I got on the board. And I think it's been going on for 7 years before that, and I've just been on the board for a year now. And to look back and see with all of these objectives and how we have them laid out, the modeling that John talks about. And if race isn't in there, is that how will that look? Because I'm thinking, we talk the disparities and how we want to make sure that we include everybody in this fight against COVID-19. And I think that if we don't break it out, how are we going to know? Because I know even here on my reservation, the Umatilla Reservation in Umatilla County, we have not had anything on the reservation yet, but we did have one at our casino early on, and but that person was not a tribal member or didn't live on the reservation. I don't even know where they live. They don't say where anybody lives. They just go by county. So, but I'm just concerned, how we talk this health equity, and then yet we don't say, well, are we covering, are we getting to all the people that we talk about that we want to with what the health equity is trying to do.
Yeah, really appreciate that.
Maybe it's too. Is it too sensitive or too what or?
We are, and I believe Lily may know. I think we are disaggregated information out there. We always, of course, run into sort of small numbers issues. Those numbers are small, and Lily, you know off the top of your head where we're at with that. If not,
Hi. Thanks for bringing this up, Lucinda. This is Lillian, and we are, as Dr. Jean mentioned earlier, we have enough. We have a critical mass, if you will, of tests that we feel that we will be able to disaggregate that and make it public on the website now as well. There was a real fear in the beginning. It's not like it's HIPAA protected or personal health information, but there's been a number of instances of people being harassed, et cetera, and we wanted to make sure that we protect people's confidentiality around that. We've had a couple instances where community members were not compassionate once they understood who in their community was affected. But I think what's happened now, we are able to say that we will be doing this. We, again, will, just like we do for any kind of disease reporting, if it's too small of a cell, we'll say too small to say anything about. Particularly, we will probably not be doing that county by county in the same way. You'll see there's male, female, there's hospitalized, non-hospitalized, and there's age, and we haven't put them all together on the same chart. Because across our state, particularly in some of our rural and frontier areas, it's too easy to figure that out. So we appreciate this, and we do feel that it is really important information, particularly as we get into that second stage when we will be really looking to work not only in the community but with communities to make sure that we can have mitigation efforts that protects smaller cell sizes of community members. But thank you for bringing that up.
Thank you.
I have a follow-up question connected to that, because I think one of the concerns I have when we're sort of trying to, sort of like look at data, particularly like racial demographics, and sort of make connections to who's being impacted the most. Like my concern is that one, there's probably a huge undercount because there's not a lot of the testing capacity is so low. And two, who has access to the testing, right? I think that the race and ethnicity demographic data could be really skewed because just a lot of people of color may not actually even have access to healthcare or have access to the tests themselves. So while they may be experiencing the disease or the virus, they may just be kind of like self-quarantining, not even calling or. So I'm kind of curious to know, like, how would you track that, or how would you sort of like capture that information as well?
Really, there's no good way to track that information. We hopefully can get to that place where we have community connections. We know that we, like Kara was pointing out with our call with providers in our nonprofit sector, we are getting feedback from them as trusted sources. And we work very closely through Julie Johnson with the tribes, and we have had a good relationship with 9 tribes through our health preparedness and public health preparedness program. So we are really right now having to wait until we have that capacity, and also want to make sure that we move forward in a way that establishes and confirms that the community would trust us around things like surveillance.
Thank you, Oscar, and thank you, Lillian. Well, we're getting to the top of the hour. I also wanted to let everyone know that we now have a mechanism for public comment, whether it be an email. And Jeff, can you share the email address?
I can, yes. And it's also on the board website, so if you just Google Oregon Health Policy Board, you can find it there. It is healthpolicyboard.info@state.or.us. Health Policy Board is one word.
So we will collate any public comments between meetings and then cover them during the meetings for future meetings. And also wanted to remind Oregon Health Policy Board members to feel free to reach out to me as questions come up in real time. We're happy to organize those questions and make sure they get to the right place at the Oregon Health Authority. And with that, I think we are at a close. I'd like to once again congratulate OHA for the great work they've done. I think every citizen, every healthcare worker owes them some thanks for making sure that we can respond thoughtfully and timely to limit the impact of this virus. And thank you for the Policy Board for your great questions and discussion, as always. And look forward to being in contact. And please be well and be safe.
And hey, Dr. Bainsberg, before everybody takes off, I just want to add, I really appreciate everybody's support and positive words. And like I said, we'll get that to staff. I also just really want to make sure, I know I've said it a few times, but I also just really want to make sure folks realize that we're not in Spotsville to really rest on our laurels. We've got, a marathon, if not several marathons, still ahead of us. And so really appreciate the board's support, but also really want to emphasize that we still have a long road ahead of us and a lot of work. And I think, again, it's going to be really critical that folks continue to do social distancing and things of that nature. So appreciate the board's support, and also know that that from our end, that means we're nowhere near being able to let up from the gas either.
Well said. Thank you, Debbie. Yes, it will be a marathon of the century. So thank you all, and please be in touch as questions come up, and happy to address them and look forward to next time we get together. Thank you.
Thank you.
Thank you. Thanks all. Thanks all.